Hello, everybody. You can be a cancer survivor or a victim of cancer. You'd rather choose to be a cancer survivor. It's more about the mindset. This is Dr. Nikarika, and we at Star Health have taken the initiative to raise awareness about a life-threatening global disease known as cancer on the occasion of World Cancer Day, the 4th of February. It's my honor and it's a pleasure to welcome our esteemed guest, Dr. Arvind Krishnamurthy. He's a professor and head of Surgical Oncology at Cancer Institute Adyar, Chennai. He did a super specialty at the prestigious Tata Memorial Hospital in Mumbai. He's authored several international publications and he's also the Honorary Secretary of Indian Society of Oncology. It's our pleasure to have you, Doctor. Thank you so much for joining us.
Thank you.
Would you like to say a few words before we start?
Yeah, I think it's my pleasure to sort of be here. And as you all know, that cancer is one of the major causes of morbidity and mortality among the non-communicable diseases. A lot of changes have happened in the global and the Indian scenario, and I think over the course of the next half an hour or more, or possibly an hour, we will try to sort of try to cover a bit of what cancer was, what cancer is today, and what is the future. So looking forward for this engagement.
So that will be our goal, to raise more awareness about cancer, and hope all your questions are answered in this session. So starting off with, can you tell me about the cancer prevalence and the trend over the last decade?
I think it's very important to understand the magnitude of cancer prevalence. The last reliable source of data was the Globocan. Maybe close to 19.3 million new cancers was the incidence, and close to about 10 million deaths. When it comes to the Indian scenario, I think close to about 14 lakh cancers and maybe about 8 to 9 lakh deaths have happened. But if you see the trajectory, what's projected is that over the next 5 years, there is some Indian statistic to suggest a marginal increase in the incidence of cancer. It's not an alarming increase, but nonetheless it's concerning. So maybe around a 12% increase over the next 5 years or so. So that is what the projection is in the years to come.
All right. Can you tell me about the gender bias in terms of cancer and how will it spread worldwide, and in terms of Indian context?
Yeah, that is there is a subtle difference between the global and the Indian context, but in the interest of time, I thought I would largely focus on the Indian cancers. If you see, there is a gender divide between the cancers. Among the women cancers, if you see predominantly, generally in the majority of the registries, the women cancers seem to outnumber men cancers to some extent. And if you see the top 5 cancers among women, they are entirely confined to the reproductive organs. Breast cancer is the number 1, cervical cancer is number 2, and ovarian cancer is number 3. The other 2 cancers, that is the oral cancers, which is incidentally one of the top cancers among men. And one of the other cancers is the bowel cancers, which is also the 5th common women. But if you see similarly, among men, it is the oral cancer that trumps everything. Lung cancer incidence seems to be on the rise. And it's maybe in some areas it may have overtaken oral cancers as well. But by and large, oral and lung cancers are number 1, the number 2. It is closely followed by the stomach, the bowel cancers, essentially, and the esophageal cancers as well. So these are the sort of broad trends. And among these cancers, if you see, both globally as well as in the Indian subcontinent, cancers of the lung and breast seems to be increasing. Whereas cancers of the cervix and esophagus seems to be, or possibly the stomach, seems to be on the decline. There are certain cancers, for example, brain cancers and esophageal cancers, which tend to be stable. So if you see that complex cancer, the cancer per se is very complicated. There are cancer can affect from the head to the toe, but then we tend to sort of study cancers as subsets. And what data I'm sharing with you, or rather what I've shared with you, is based on the subsite division of certain cancers. And it's very important to understand this, the magnitude of all cancers plus the subsite specific cancers.
All right. So what are the common risk factors for getting cancer?
That's $1 million question, in fact, if you say.
If you can just flatten it and put it across.
As I said, broadly, if you say from the pan-cancer perspective, there are two major risk factors as how we classify it, and that's one way in which we classify the risk factors. One is called the non-modifiable risk factors. The other is called the modifiable risk factors. For all practical purposes, your age, gender, of course, now you have the option of changing gender also, but we'll not go into that. That's a completely different topic in itself. And your genetic makeup, by and large, you cannot change these buildings. So when you have, for example, pediatric cancers or cancers that is related to age or genetic makeup, not much can be done about these cancers. But there is a host of other factors called the modifiable risk factors, and majority of the modifiable risk factors are related to lifestyle factors. And the lifestyle factors is something that we all know. It's commonly known. Like, for example, tobacco in any form. And in India, you have more of weedy smoking and smokeless tobacco, alcohol in any form, then lack of physical activity, some amount of dietary habits, poor dietary habits, exposure to ultraviolet rays of the sunlight, and certain other occupational hazards and certain infections. So broadly, these are the risk factors for cancers. And if you want to study to a subsite specific, then there would be certain more amount of some cancers will have specific risk factors than others. But by and large, what I have alluded to, tobacco, alcohol, physical activity, this includes obesity, diet, infections, they by and large contribute to the lifestyle factors. They are the non-modifiable risk factors for cancer.
All right, thank you for that, doctor. Could you shed some light on the diagnostic modalities, the latest trends, and who should be getting diagnosed to check if they've got any malignancy?
Yeah. So again, the core diagnostic modality of cancer is based on a biopsy. And a biopsy can be done through a needle, or it can be done through a large bore needle, or it can be done through a sort of other open procedures. So by and large, what happens is, by a biopsy, it means that we are studying cells, or more importantly, tissues from the affected body part of the cancer patient, and we are studying it under the microscope. So that gives the basic diagnosis of a cancer. Additionally, what happens is that sometimes we do certain advanced tests in the tissues itself called immunohistochemistry. Sometimes you do molecular analysis of the tissue type to study for specific mutations, and more so that can be targetable. But at this point of time, there's a lot of buzz on non-invasive modalities. For example, if I were to stick in a needle or a large bore needle into the tissue, it's called as an invasive procedure. So nowadays, there's a lot of trends for minimally invasive. That is, you tend to detect the cancer cells in blood or in other samples also. And this technique is called as a liquid biopsy. Of course, it's a very exciting field, but a large amount of progress is needed to be done. A lot of work is being done in this. It is there in the treatment or in the management of certain cancers, but it is an exciting new way in which cancers may get diagnosed. But I must reiterate, the traditional way in which a majority of the cancers are being diagnosed right now are by studying the tissue under the microscope and doing additional tests as and when warranted.
All right, doctor. So in case if a person has a genetic predilection for say, they have two generations of CA breasts that have come across. So at what age should they go get a consultation or look for warning signs? Can you please elaborate on that?
It's a very, very important question, very pertinent question as well. Prior to answering that specifically, I must add that close to 90% of the cancers, and in this case, you specifically asked about breast, so 90% are sporadic. That is, they do not have any genetic predilection or there is no family history. But it is the 10% that may have some amount of genetic mutations. So what happens is that we classify the patients based on risks. And a normal person has got an average risk of getting a cancer, and the incidence may vary, maybe 1 in 28, for example, of breast cancer. There is again an urban-rural divide. If you're in an urban area, then the chances that you're getting a breast cancer may be slightly higher, because again, some amount of risk factors that are associated with breast cancer seems to be higher in the urban population than in the rural population. When it comes to specific genetic mutations which run in families, it is based on certain genes. And we triage those genes into two types broadly. We sort of say it's a high penetrance gene in which, and the classical example are the breast cancer associated genes called the BRCA1 and BRCA2. And it's become common that a lot of people know about this following the Angelina Jolie effect. Essentially, yes. All knew that she harbored one of these deleterious mutations. It ran in their families, and she underwent a prophylactic surgery after that. And there are other genes that are caused as moderate penetrance genes. And in these genes also, there is a slightly higher risk of developing breast cancers. And there is a third sector called as variants of unknown significance, with which we don't really know whether these genes are harmful or deleterious. But having said that, your question was spot on. How does a common man get to know whether they are harboring these genes or not? And the most important and the most easily done thing is by means of a family history. So if you are having a family history of breast cancer, and especially if they are younger, if you have it in your first or second generation, if you have male breast cancers, if you have ovarian cancers, if you have anybody with prostatic and sort of pancreatic cancers, or if you have certain lineage, for example, certain Ashkenazi Jews seems to have certain higher predilection for breast cancers. If you have a family history, then there is a chance, mark my words, there's a chance that it may be due to one of the high-risk penetrants or one of the deleterious mutations. So having a family history of a cancer means that you need further evaluation. That is all I want to say. You need a genetic counseling, and a genetic counseling it has many components. The pre-test counseling, there's what actually happens in the test, and there's what is called as a post-test counseling, and we have specific genetic counselors who actually go about doing that. So in short, I must say that the genetic risks of getting a cancer is close to about 10%. A family history in some form is an indicator you may be having it. There is a chance that you may not be harboring any one of these mutations as well. But it is an opportunity for you to discuss with your family doctor or oncologist, understand the implication, and then prior to subjecting yourself to a genetic test and the further management of a normal person harboring a genetic mutation or a cancer patient harboring a genetic mutation is slightly different. That's a very complicated topic, and I've tried to actually simplify it in some ways.
Thank you so much, Doctor. That was very insightful. So next, I'd like to know how, if a person is not aware of their family history of cancers, so in that case, what are the warning signs that they have to look after so that they can know that, okay, it could be cancer and I should go check it out with a doctor?
Yeah, again, this is a very common question that's asked generally by people and families, and in majority of the programs we get thrown this answer. And I must tell you, there is no right or wrong things in terms of symptomatology. For example, I will tell you an example of, say, we discuss about breast, so let's discuss a certain adjacent organ called lung cancer, which is again a cancer that is increasing. So the common symptoms of lung cancer would be a cough, would be a hemoptysis, there is some blood in the cough, breathlessness, there is your shortness of breath, loss of weight and loss of appetite. But if you see common disease that is there in the Indian population is tuberculosis, and you know that India is one of the endemic countries for tuberculosis, although the incidence seems to sort of be coming down for other reasons alone. But still, again, there is a challenge of multi-drug resistant tuberculosis as well on one side. So, but of course, we're not going there. But the symptoms of tuberculosis would be again cough, hemoptysis, breathlessness, loss of weight, loss of appetite. So if you see, they're exactly the same. So for a common man, it may be slightly difficult for them to sort of diagnose or be reassured that they have or they do not have cancer purely based on symptoms. Yes. But for certain organs, visual organs, like for example, if you have an oral cancer, then if there is a non-healing ulcer that is persisting for a longer time, if there's a breast cancer, sort of a lump or bloody discharge, or that's the warning sign. If there is a bowel symptom, long-standing constipation. So again, these are some of the red flags. What I would suggest is any symptom that is persisting for a prolonged, any unusual symptom that is persisting for a prolonged period of time,
or that as in, can we give it a duration?
Maybe many weeks, okay. I think by a month or so or something. Like for example, okay. If you have a cough, you expect it to go off in a couple of weeks. Supposing you keep on coughing for a period of a month or more, what I'm telling is that I don't tell you that you have lung cancer, but I tell you that you need a scientific way of evaluating it to rule out particular tuberculosis.
It's also pretty common that some patients who have symptoms for a pretty longer period, for say a few weeks later, and they straight away go into Google and they try to find out what it could be, and the first thing that comes up is cancer. So it's very common among
I know. I think a lot of people do tend to sort of Google, but I must tell you, a lot of times I think people land up more confused.
Yes.
And then, but I would suggest that it's preferable that, of course, Google does help. It does have a lot of some trusted websites do have good, authentic information, but at the same time, you do have a lot of these myths as well that are there. So please verify the content a number of times, and preferably consult your family physician or an oncologist if you feel the need to, in case of any alarming symptoms that persist beyond a certain period of time. So that would be my short answer to your question.
All right. Thank you, doctor. So could you tell us about what are the advancements in treatment of cancer and the lifespan and the stigma attached with it, and what goes along the whole journey of a person who's got cancer?
That's again a very important, very complicated issue, because cancer, when we talk about cancer, a lot of times we speak only about physical ailment that occurs to the individual. Like for example, there is a body system or an organ system that tends to be affected. But then there are many other dimensions of cancer as well. You have the mental dimension, there are socio-economic determinants, there's a familial component, there's a spiritual component, and there are a whole of a lot of components that are actually associated with cancers. So by and large, what we tend to do is that we address all the components. When we sort of manage a patient with cancer, it is not just the patient, it's the caregiver and the family as well. So because the cancer is a disease that not just affects the individual at large, but also the immediate close caregivers in the family at large. So when we manage a patient with cancer, we sort of manage their families, and we try to address all these components, because it's very, very important to understand the mental, the psychosocial, the economic, and the spiritual dimensions of cancer, because each of these dimensions can affect the management per se and the ability to complete the prescribed treatment and that in turn determines the prognosis as well. So we do have specialists fortunately available at this point of time. A lot of social workers can look into the economic and the financial perspectives. Maybe we can talk about that later. We do have some trained counselors and psycho-oncologists on board, and we as clinicians are trained to identify distress among patients. So, and we have a distress thermometer in which we actually measure the distress of these patients. And any distress more than a particular scale, say 4 or more, we refer them to trained psycho-oncologists. So, in short, we function as a team because cancer is complicated. It requires a multidisciplinary management of care. And all the other people are very, very important components or very, very important stakeholders in the ultimate management of these patients, essentially.
All right. Yes, so as multidisciplinary it is, we got to know about that. Could you tell us about the monoclonal treatments, antibodies that are being used, the recent advancements currently to treat cancer?
Yeah, I think that is specifically to address the systemic therapy options. By and large, cancers are addressed in 3 major modalities. One is, of course, surgery, one is radiation therapy, and what you said, monoclonal antibodies are part of the systemic therapy for cancers. And among systemic therapies, you have the traditional chemotherapy component, you have the monoclonal antibody component, and you have the immunotherapy component as well. So these are certain ways in which particular drug is given through the bloodstream of the patient so that they can act specifically on a particular target. In case of chemotherapy, what happens is normally what happens is every cancer cell or every cell in the body, rather, including a cancer cell, goes through a process of cell cycle. And that uncontrolled proliferation of the cells is what is the root cause of cancer, if you see. And chemotherapy tries to address these replicating cells by disrupting the cell cycle pathway. And if you see a monoclonal antibody, it also tends to sort of act on a specific target, and it causes a downstream effect. And of course, immunotherapy, we can come to that subjectively.
Okay. Could you tell us about the radiation therapy and its advancements now, and how important is proton therapy now and its indications?
Yeah, proton seems to be the buzzword, and for many reasons. Of course, we are sitting down in Chennai right now, and must be proud to sort of say that Chennai is the first center, first city rather in India to have the proton therapy facility. But having said that, I must say that world over, the penetration of proton therapy is very, very less. It's a latest development. Of course, proton therapy has been there for many decades, I must tell you. It's actually got the buzz pretty recently, and in India, you have had it for about just maybe closer to the COVID pandemic or so. A lot of buzz about proton therapy. Of course, a lot of technical advantages in terms of relative biological effectiveness and possibly some immune modulatory effects of the proton. But by and large, the use of proton therapy is for certain tumors, like for example, certain pediatric cancers, certain ocular tumors, certain tumors of the base skull, in which you really need a high precision without having the side effects of it affecting the adjacent tissues. So if you see, these are the 3 areas wherein the use of proton has really found to be useful, and world over in many clinical studies have shown that in these set of patients, I reiterate, pediatric tumors, the ocular tumors, and the tumors that are close to the brainstem. Of course, proton has been marketed and is currently being used for many other cancers apart from these cancers as well. But I must say that the literature available is limited. We need more studies to compare the effectiveness of proton therapy vis-a-vis the traditional radiation therapy that can be used. But I must say that by and large, you don't really require proton to treat all cancers. 99% or more of these cancers can be treated exceptionally well with the traditional modalities of therapy as well. Proton seems to be the new kid in the block. It does have some relative biological effectiveness advantages, and as said in the specific scenarios, you may tend to use protons. But by and large, world over and India as well, the conventional form of the IMRT or the IGRT, what they call as the image-guided radiotherapy, seems to do as well as protons.
All right, good to know about that. And recently we had a demise of celebrity due to cervical cancer. So could you shed some light on its prevention and what could be done, in terms of management of cervical cancer?
Yeah, I think that's a really in topic. In fact, I must say that January, in fact, was a cervical cancer awareness month. So we have done a lot of work on promoting cervical cancers at the institutional level as well. Having said that about cervical cancer, and I briefly alluded to at the start of the interview, that the incidence of cervical cancers, fortunately, seems to be on the decline for various reasons. WHO, that is the World Health Organization, has given a call for elimination of cervical cancer in a preferred time frame, which I feel that it's difficult or impossible for majority of the countries to sort of observe. But they see cervical cancer as a prototype in which we can eliminate, and they have underlined about a few strategies. There's the famous 90-70-90 strategy, in which you want to have a 90% vaccination, 70% screening, and a 90% early detection and effective treatment. So by understanding the model of 90-70-90, you can get ways in which you can, and I have actually written a lot of articles on cervical cancer prevention as well. But by and large, I think to just quickly focus on each of the three modalities. Vaccination, you have had vaccines in the past as well. It was available under prescription. It was not a part of the national policy till this time, but you did have vaccines that are available. Fortunately, you also have an Indian vaccine, the Cervarix, which is manufactured by the Serum Institute, and our Home Minister had in January last year actually made it quite open. And I'm sure that in the interim budget presented by the Finance Minister, Mrs. Nirmala Sitharamanji, she actually made a mention that the government would encourage girls from 9 to 14 to get the cervical cancer vaccine. So 2 or 3 positive developments have happened in the Indian perspective. Of course, you mentioned the unfortunate demise of an actor because of this. But having said that, I see the positive side of it, that the governmental push for cervical cancer vaccination of young girls, more importantly, the availability of the vaccine produced by the Serum Institute, and it is believed to be cost effective as well. Earlier, you had 2 other vaccines available. Especially the more commoner one that was used was the Gardasil, which had a nanovalent and pentavalent vaccine that was available. And the vaccines have clearly shown to save lives. It prevents pre-cancers, it prevents cancers, and in countries that have actually not gone for vaccination, they have found an increase in the incidence of cervical cancer. So it's no doubt, I think earlier people were thinking that it prevents only pre-cancers. But now you have the effectiveness of the vaccine in large population-based studies which have been published in reputed journals. You have incidents from certain countries to say that wherein the vaccination coverage was slightly lesser, the incidence seems to have gone down. So having read the data, I do feel that there should be a sort of push for cervical cancer vaccine, and which rightly the government is doing. The other thing is, of course, cervical cancer screening. And I think now we are moving from the traditional pap smear, that was a cytology-based screening, to detecting the virus itself. It's called as HPV-based screening. And the Cancer Institute, we are one of the nodal centers in which we perform the HPV-based screening. And the third final modality towards effective cervical cancer prevention and treatment is to identify these lesions and treat them effectively.
All right, that was a great insight. Hoping it reduces further down the incidence. And could you tell us about the recent technologies for, say, artificial intelligence role in the management of cancers?
Yeah, I think I must say that I'm pretty excited as well. And everybody is. you see artificial intelligence, digital technologies penetrating into our daily lives, and both artificial intelligence, machine learning, and deep learning are expected to make significant inroads, I must say, in the way in which cancer is being managed. There are many ways in which artificial intelligence can be tapped to manage the patients. One of it is in the prevention and the diagnostic space. Um, and I must also say the other important dimension is the therapeutic space, in which you can sort of, identify precision targets, and you sort of, personalize the care for some of these patients. A lot of buzz has gone into the FDA approval of certain diagnostic devices which are based on AI. And a lot of development has happened in certain cancers. For example, in breast cancers, in lung cancers, and I told you that these are the cancers that seem to be on the rise. And a lot of devices have been approved by the US FDA towards diagnostics for these cancers. A lot of buzz in artificial intelligence has happened in the space of two major specialties, that is radiology and pathology. Slightly lesser when it comes to the core specialties, but in radiology and pathology, close to about 80% of the artificial intelligence penetrations is happening. And a lot of devices are sort of, when, for example, just to give you a small example, it's to for breast cancer prevention, one of the modalities is to do a screening mammography. And if you are to do it in a nationwide survey, of course, this is globally. So in India, you have a slightly different strategy. Maybe we can talk about it later, because in India, doing a mammographic-based screening there are its challenges itself. How the penetration would happen and who would read it, and the fact that we have some Indian data to suggest a clinical breast examination by a trained clinician after 50 years, you could sort of save lives, especially breast cancer lives. But to sort of come back to the question of artificial intelligence that you are asking, globally, I think where the penetration of screening mammography to identify breast cancer is there, it will be extremely difficult for radiologists to sort of scan through millions of screening mammography that patients have. And believe me, a lot of people have actually sort of a lot of medical legal problems have happened because radiologists have missed diagnosis of breast cancer on a screening mammography because of various reasons. And that's where I'm not faulting the radiologist, but when you scan through millions and there's an element of fatigue that sets in small lesions, that's where there is a scope for artificial intelligence to come in. And AI-based reading of screening mammograms is a huge thing, and it has come up in a big way. So I'm just giving you one example. Of course, there are a lot of other examples. For example, you have chest X-rays that are read by AI to detect tuberculosis, lung cancer, CT scans also AI detected. You have in the pathology space also, and you have, as I said, the diagnostics and the therapeutic space as well.
All right. Okay. So coming to the financial implications that cancer survivor goes through, could you tell us about the stress that they go through in terms of finance and when emotionally, and since you keep seeing cancer patients day in and out, so what would you like to tell them?
Yeah, let me focus on the financial aspect, because we did briefly touch about the emotional aspect. When it comes to emotional aspect, it is not just to the patient, but also to the caregiver. And we measure distress in the distress thermometer and triage these patients to get specialist help. So managing emotion is a very important component. It is not just for the patient, but the caregiver as well. And we have specialized mechanisms in place. But with regards to the finances, I think it's very important to understand. Many years ago, cancer treatment was one of the prime reasons for driving patients and families into poverty. This is because that comprehensive cancer treatment, especially in advanced stages, is costly. So let's get the facts right. So detecting cancer early and treating them early is one way in which you can sort of reduce the number of modalities that you use for the treatment of that particular individual and thereby reducing costs. But the more advanced the cancer goes, the more complicated the modalities and the costs also are prohibitively higher. And you didn't really have the penetration of insurance in India as much as that we see today. Fortunately, I think, and thanks to a lot of initiatives taken both by the central and the state governments as well, and one of the flagship schemes of the Ayushman Bharat that's come since 2018, the penetration of Ayushman Bharat, and thanks again to the present government in the interim budget, they said that they would extend the benefits of Ayushman Bharat to the ASHA workers and the Anganwadi workers and the frontline health workers as well, which is a positive development from the government of India. The flagship Ayushman Bharat scheme seems to sort of address these disadvantaged sector by giving them some amount of money for a period of time, and it covers cancer treatments as well. You do have every other state government also rolling out a lot of schemes for the disadvantaged section of people. Of course, on the paying side, the private, you do have a lot of private insurance companies also that cover not just for preventing or that is you're an ostensibly normal person. In case you have a cancer, there is an insurance scheme for that in terms of a wellness policy. And there are also insurance players who are offering insurance also to patients who have been diagnosed with cancers as well. And this is something that's a really exciting thing. But having said that, I must say that it is not just up to the management, the costs, but a lot of out of the pocket expenses also are associated with cancer treatments, which can be twice or thrice the cost of the normal cancer treatment as well. For example, if supposing a patient is from, say, somewhere else, and he travels to, say, a patient from the northeast, and we do get a lot of patients from Assam, from Kolkata, and so they come here. So for the entire duration of the treatment, they have to stay put here, loss of livelihood, they have to fund for their stay, their food, and all those. So those expenses are something that is not actually captured in a systematic manner. So if you see, the costs of treatments are not just the actual costs of the treatment for that individual per se, but also for the caregiver, for the loss of livelihood that he or she has to undergo, plus the out-of-pocket expenditure. Unfortunately, we have some insurance, both government, central, state, and a lot of private insurance players that are in the market to sort of help out some of these patients.
All right. So the theme for World Cancer Day this year is Close the Care Gap. I guess we've covered most of it. Dr. Arvind had guided us. Would you like to add some more? Close the Care Gap.
Yeah, absolutely. I think the February 4th happens to be the World Cancer Day. It's celebrated every year. It's the UICC sort of, it's one of the flagship events of UICC members. I'm a part of the, of course, I'm an oncologist and I do a lot of course, my core job is to operate. So I do a lot of surgeries, including complex surgeries and robotic surgeries, especially for the head and neck, esophagus, and other breast cancers as well. But I do sort of take time to engage with the various stakeholders, the general public, plus various other general family physicians, general physicians, students, etc. in this. And also I'm a member of the Indian Society of Oncology, which is a member of the UICC, incidentally. So we, not just as an individual or an organization, participate in the World Cancer Day activities, but also as a part of the Indian Society of Oncology, we do some events towards this. And the theme, that is the Close the Care Gap, is the theme for about 3 years. So it's been from, I think, 2022 to 24. And this is the end of this year. And from 25 onwards, the theme will be different. And the theme, by and large, was to sort of, address the equity threat that is happening. Because what happens nowadays is where you are born, where you are living, and if you are having a cancer, all these two things matter in terms of life and death for that particular patient. So that is something that we must try to address. For example, if you are there in a metropolitan city, like for example in Chennai, where we are at this point of time, and you are in an affluent family, then your ability to access, afford treatment is there. So you get quality care and the chances of being there. But at the same time, if an individual is there in some remote rural areas, and believe me, 75 to 80% of India is rural, then you do have issues of accessibility, affordability of treatment, and also availability to a certain extent. So close the care gap is trying to address these three issues of access, availability, and affordability for treatment. And fortunately, we all are doing our bit in some ways. We, as the Cancer Institute, in which about 20% of our cancer patients are treated free, 40% treated subsidized. So we are doing some bit to sort of address this issue. The government, as I briefly said, by having these schemes of Ayushman Bharat and getting a lot of the disadvantaged patients under this bracket, so it's doing its bit to address the equity gap. So each one of us are trying to sort of address the equity gap, but I believe there's a lot more work that needs to be done.
Absolutely. It's good to know that we are indeed closing the care gap, but there's much more to be done. Could you tell us about the palliative management aspect that a cancer survivor goes through? And you spoke about the mental aspect, the physical aspect, and of course, the burden that the family also goes through for a cancer survivor, but in specific, just the palliative portion of it. Could you please highlight that?
It's exceedingly important. I must say, palliative care, it's getting some traction and attention, and rightly so, in the coming years. It was initially a not much addressed field, but I must say that if you are a comprehensive cancer center, and if you are managing patients, palliative care is one of the pillars of management of these patients. And there is a certain distinction that I want to draw here. Palliative treatment doesn't always equate to end-of-life care. There is a normal perception. They think that palliative treatment is end-of-life care, the care that you give for a person who is destined to die. But the scope of palliation is much beyond. In fact, if you see the way in which palliation is sort of integrated into the normal cancer care, it actually starts the diagnosis of some of these patients, in which you sort of subtly integrate palliative care. And there has been some studies, for example, in lung cancer specifically, where it has shown that integration of palliative care into the normal care actually tends to prolong life. So end-of-life care, I must say, is a part of palliative care. And now you have places offering palliative care as a sort of a specific care for these patients. You do have certain courses that are run for palliative care, certain fellowship courses, like the Indian Association of Palliative Care undertakes certain fellowship programs to sort of train doctors, nurses, and other caregivers in palliative care. You do have some courses run by the government also. The DNB palliative care program is there. So a lot of attention is given to this. And I must say that no cancer facility can be considered comprehensive if it doesn't have the branch of palliative care. And the scope is enormous, I must say, that to be in short.
All right, that sums it. So, as the last question, I'd like to ask you just 5 points that you'd like to tell the audience across on the creation of World Cancer Day.
Well, we've discussed more than 50.
Yes, we can discuss just a short summary of what you'd like to inform the audience, the common people.
Yeah, I must say that, cancer incidence seem to be slightly increasing, not alarmingly increasing. One has to sort of respect one's body, know one's body. And the large focus should be on wellness rather than sort of, cancer prevention per se, So, in which I think, and specifically when it comes to cancer prevention and wellness, I think there are certain common topics. So you can prevent about 50 to 60% of the cancers by staying away from tobacco, alcohol, maintaining an ideal body weight, doing some amount of physical activity, and sort of, and for women especially, breastfeeding seems to sort of, be protective against breast cancers per se. And with regards to diet, I think eating a well-balanced, wholesome diet, rich in fruits and vegetables, have shown to be protective. When it comes to cancer prevention, of course, you all need to be aware. And I think the whole idea of this interview was to sort of spread the message of certain early risk factors, certain signs and symptoms, and red flags for cancers. And even by chance that you get cancers also, I must say that a lot of advances have happened in the space of all cancer modalities: surgery, radiation therapy, systemic therapies, immunotherapies also. Like, I know we didn't really touch upon that. Of course, although we spoke comprehensively, now what is happening is the average lifespan of an individual seems to be sort of increasing, and in India is closely touching close to 70s or so. And what is happening is, with the advances in cancer care that is happening, we are seeing some long-term survivors because of immunotherapy, even in a stage 4 advanced metastatic cancer where a precision medicine could be given. So I think that for me is the biggest advance that has happened. Although a lot of these incremental benefits may be marginal at this point of time, but I'm hopeful. The story of cancer is sort of evolving. A lot of work is being done. We are also part of the journey. Our job is to sort of, educate patients, families, treat patients, but more importantly, we want to contribute to oncology so that life of a cancer patient can be better in the years to come. So the component of research is also very, very important, and we are trying to sort of, do our bit on research. A lot of research actually emanates from the West, and we tend to follow most of them. But I'm happy to say over the years, we do have good Indian data coming up from our centers. And I would encourage patients also to sort of be part of some of these research initiatives so that you can benefit and you can benefit the generations to come.
That's good to hear, Doctor. We at Star Health, we cover management for cancer survivors according to underwriting norms. What would you like to add on regarding the health insurance coverage for cancer patients?
No, I'm really happy. Like, what I said was like, the insurance penetrations were very, very less many years prior. Now, as I said, you do have insurance, not just from the central government, the state government, and a lot of private players also are coming and aggressively pitching their products. Of course, the Star Health, of course, I'm aware of a couple of the products in Star Health, and they do offer, for me, one of the products that I'm really excited or happy about is the scheme in which they offer insurance for patients who are diagnosed with cancers as well. I think maybe it's one of the flagship schemes, I must say. So there is hope that, of course, even though you're diagnosed with cancer, at least to a certain extent, you are sort of, covered. Of course, I'm sure that, you would have all the clauses that you'll have to really glean through. But at least there is a segment of population of cancer patients that can sort of, after understanding the clauses of this insurance, can avail. Which a lot of the insurance players are coming to pitch in for this segment of population that was traditionally having no cover earlier.
I really hope this session was very useful for all of you all. I'd like to thank Dr. Arvind for taking the time to come down to the office and record the session with us. Thank you so much, Doctor. It's a privilege to have you.
Thank you, Niharika. Thank you, Star, for the opportunity.